start recording and we'll just get going and then. Cool. So thank you all for coming again. This is like the third and final haematology teaching session, and this one is going to be on haematological emergencies. So a little bit will be given by me, a little bit will be given by the other Jack, and the idea was just to sort of a bit like all the other topics that we've done, or within the other topics that we've done, just give you a bit of a flavour of some of the things that crop up that are kind of more specific to haematology wards than anywhere else. So I can't remember what the next slide is. I think you just go straight into it. Yeah, so we'll do this sort of on a case-by-case basis. So the first case is you're on your night shift, and part of your remit is the haematology ward, and you get a bleep and with this comment, which is, can you review the 60-year-old gentleman with a background of AML who was admitted 11 days previously for chemotherapy and has now spiked a temperature of 38.2. So does anyone want to talk through any of the immediate concerns or what they're thinking may or may not be going on, and then maybe suggest what you would do in your approach to this patient?
Jack, just go back to the first slide. Sorry, I missed it.
Oh, no worries. 6-year-old AML post-chemo has a temperature.
Are they already on antibiotics?
Sorry?
Are they already on antibiotics? I'd want to do an A2E and find out whether or not they were already on antibiotics.
Good. Yeah, so
I've just been concerned about neutropenia.
Good.
It's all right.
It's rubbish, isn't it, like this? And I can't see any of you either because of the screen. So I think I agree with you. First thing is an A2E assessment, as with all sort of potentially poorly patients. So working through that process is obviously very important. And then you made a very, very good point about, is the patient on antibiotics? And you quite rightly pointed out that you'd be worried about neutropenic sepsis. So anybody with a hematological diagnosis is potentially neutropenic. Anybody that is post-chemotherapy is potentially neutropenic. Anybody with a hematological diagnosis post-chemotherapy is almost certainly neutropenic. So you need to be thinking about neutropenic sepsis. So yeah, I think that's kind of what we went through. So this was actually borrowed from the teaching we did back in 2016, I think. So we said do an A3 assessment, so check their airway, that's fine. Breathing wise, oxygen saturations are all okay, respiratory rate fine, no creps on the chest. Cardiovascular status, blood pressure is a little bit lower than normal at 101, but not too bad. Heart rate is about 106. They're alert, they're talking, their blood sugar's fine. And then we said check everything. So we've had a look all over them, abdomen soft and untender. There's no obvious rashes or obvious source of infection anywhere else. I've written here allergy status, so obviously making sure there's no issues with anything that you might want to give. Full set of blood, as you tend to do these patients that might be potentially septic, including a lactate, which our nurses are very, very good at doing when a patient spikes. And then the other thing is to culture everything. So in these situations, there can be any number of causative bugs, drugs, anything like that, even the diseases themselves. So it's really important that we try and, if it is an infection, try and hone in on what the infection might be. So we want to take some blood cultures peripherally, and if they've got a line, you want paired cultures from those as well. Urine samples, swabs of anything that might have pus or anything like that, sputum samples or anything that you think that might contain a bit of an infection that you can get hold of, just send off. And obviously, as part of your A2E assessment, you should be considering supportive treatments like oxygen or IV fluids and that sort of stuff. So you mentioned antibiotics before. What are you thinking with regards to antibiotics in this patient? Give them, not give them?
give I'd give is it Taz and Gent we give them when they're neutropenic if they're not if they haven't got a penicillin allergy. Is that right? Can you hear me?
Yeah, well, we'll come to that. So we'll come back to the antibiotic question, but I don't disagree with you. So what we were worried about in this patient is neutropenic sepsis. So this slide again was in one of the previous talks that we've done only a couple of weeks ago. But it really just needs to be absolutely hammered home. With neutropenic sepsis is a deadly complication of chemotherapy treatment. Untreated, up to 1 in 5 patients can die. So it's something that we try to take really very seriously. And we tend to define neutropenic sepsis in Sheffield as a temperature of 38 or more with a neutrophil count of less than 1. So I know here it says 0.5, but we tend to take that neutrophil count of less than 1. The other thing to consider is that the neutrophils are less than 1, but there's no fever. Even if the patient just looks, really poorly, like they might be septic, actually that can be a defining feature of neutropenic sepsis as well. I can think of a couple of patients recently where they weren't spiking, but they did just look dreadful, and we treated them, and it turns out their lactate came back high, and blah, they ended up growing bugs in their blood. So I think the take-home message here is, in the haematology patients that you see on the ward, you worry about neutropenic sepsis, and you should have a very low threshold for giving antibiotics. I've said this before, I'll say it again. You're very unlikely to be criticised in any way, shape or form for giving a patient a shot of antibiotic in the middle of the night if we're not sure what's going on. But you're much more likely to run into problems if they don't get it, because these patients tend to get infected with these gram-negative organisms, and I'm sure any of you that have got critical care background or you've seen it before just know how quickly people with gram-negative sepsis deteriorate, but actually how quickly they recover of antibiotics. So giving antibiotics early is very important in this setting. So you're asking about which antibiotics that we give. So you're quite right. So for most patients on the haematology ward, so that's all non-transplant patients and those having an autologous stem cell transplant, we tend to say that first-line antibiotics are tazocin, which is QDS, not TDS, and if suitable, gentamicin as well. So by suitable, I mean that they've got no contraindications like a really poor renal function or anything like that. If the penicillin allergic, if it's just a mild thing like a rash, we can give ceftazidime in place of the tazocin. And if it's a severe allergy, we can think about discussing it with micros. So sometimes we give ciprofloxacin and ticaplanin. Sometimes we have to give slightly different cocktails of drugs that are less familiar. So in those situations, in the middle of the night, perhaps talk to one of us, or there might already be a plan in place that we can consider. The slight caveat to neutropenic sepsis in haematology is the allograft patients, the allogeneic stem cell transplant patients. So their first line is meropenem and ticaplanin. The reason for that is that these tend to be very kind of multiply treated patients, both in terms of chemotherapy and antibiotics, and they're much more likely to have a resistant bug driving this. So bugs that are resistant to basically penicillin. So we give meropenem on the basis that it's more likely that they'll grow something resistant to tazocin. And again, with penicillin allergies, we end up discussing those with micro. Just we have to have a bit more of a think about what we're trying to cover in that setting. So this was Jack's slide, and I couldn't agree more with it. So, if the neutrophil count is less than 1 and fever, give the first dose antibiotic within 1 hour, and don't wait for blood results. So I guess you wouldn't necessarily know that the neutrophil count is less than 1. So that means in certain patients where you don't know the neutrophil count, you have to presume in the haematology patients that they are neutropenic until you get the full blood count. There may be 1 or 2 patients that get admitted in our pathway, like sickle patients, where it's unlikely that they're neutropenic. But again, as I've already said, it's very unlikely that on the basis of 1 shot of antibiotics, which effectively is all it will be, in the night shift until someone gets to see them in the morning, you very exercise. And actually, for a lot of sickle patients, there's usually some kind of infectious driver anyway, so you'll see that a bit later on. So the take-home message here is don't wait for blood results. If it's a haematology patient post-chemo and they've got a fever, give antibiotics and give them within an hour if possible. Oh, I missed them. That's annoying. Maybe they come a bit later. So moving on slightly. So this is a slightly different situation. So that was kind of taking the patient after their first fever, which, you know, tends to be the nice and straightforward one because you just start with the first lot of antibiotics as we've discussed. But this is the same patient now. So there's been, so you saw them a couple of days ago and you started TAS and Gent, and we saw them in the morning. We very much agreed with you and we continued those things on. So we're 48 hours in now to these antibiotics. The patient's neutropenic, I think neutrophils are 0.01, but they're still having fevers. So is there anyone else is thinking about what, or, you know, what you might want to consider, look for? What else might you want to do?
John, did you want to add something?
Yes, I was just wondering, on the blood results section, you mentioned a CLS. I'm not familiar with CLS. What is it and what are we looking for?
Oh, it's just a clotting screen.
Okay, cool. Thank you.
So I think sometimes when you do these teaching, you know, clotting screen cannot be important, but I think when we're doing these teaching sessions, the clotting screen in the context of sepsis, I guess you're considering just having a baseline to look for things like DIC. You know, unless the patient was bleeding, I'd probably forgive you for not sending it, but that's what it meant.
Wonderful. I was just making some unusual hematology test I'd never heard of.
No. It's just my stupid abbreviations. I'm sorry. As you know, in haematology, we absolutely love abbreviations and acronyms. So
thank you.
That's all right. So, any thoughts on what to do in this situation?
We probably need to reculture and try and find source and potentially change antibiotics, either if there's a plan or escalate to a different one or add a different agent in. Yeah,
so pretty comprehensive that. So I think the first thing to say is, yes, absolutely. Let's start by trying to find something again. So at 48 hours, we tend to, unless it's something new that appeared within that time frame, we tend to suggest sort of reculturing everything. It's surprising that the things that you can pick up at this stage, as the other bugs have been sort of selected out by the antibiotics. So it's really important to, you know, do your A to E approach again, and then basically reculture everything. And again, the nurses on the wards are brilliant at basically having on the handover when the patient last had cultures, and they'll sort of as a routine, wherever possible, get you those repeat cultures and that lactate and everything when that patient spikes at this setting. So I suppose from your side of things, it's what do we do in terms of assessment, but also antimicrobials. So there is actually a guideline for this, and much like some of the other haematology guidelines, we don't always follow it. So if you look at the first patient, which is a non-transplant autologous stem cell transplant patient, what we tend to suggest is a couple of things. So if the cultures are negative and things are settling down, then actually 48 hours of gentamicin is often enough, and to prevent any issues, we can stop that. But actually in our patients, it's the opposite, isn't it? They're continuing to spike, and we're not quite sure what's going on. So there's probably two schools of thought in this setting, and depends on who you work for in the day on haematology as to what you end up doing. So the guidelines actually state that what you should do is, as you've said, reculture everything, and reapproach the patient to make sure there's nothing that you've missed that perhaps you should be covering. But if the patient's not clinically deteriorating, then perhaps you could actually continue the first line antibiotics for a further 48 hours and to see what the response is. Occasionally it can just take a bit of time to settle down. The other school of thought is to do all the reculturing and then at this point, sort of every 48 hours, consider a change of antibiotics. And I think the decision to do that is probably slightly more nuanced in the sense that it depends really what you think is going on. And I think it probably takes a bit of streetwise and experience in this situation. So we as the haematology regs and consultants and things know which patients we're worried about, and we kind of had that little bit of information in the background that we knew that they'd grown that resistant bug 6 months ago or whatever it is, and we just have a bit more of an inclination here. So I think from your perspective in this setting, it would be absolutely reasonable to go and assess the patient and then just basically have a chat with us about what we want to do. And occasionally we'll just say, do you know what, just carry on. But sometimes we'll say, actually, do you want to, you know, at this point, the patient's got a line, maybe add typhoplanin for some gram-positive cover or something like that. And then moving through the guideline, sort of when we're getting to 96 hours, so 4 days, a sort of persistent fevers, then we really have to consider other sources of infection that aren't bacterial. So at this point, we tend to suggest a couple of things. So I think someone, I'm trying to remember if it's anyone, but I can't remember who it was, rang me about a patient in this situation not that long ago on a weekend. And basically what we tend to look for is sort of fungal infections. So in order to look for a fungal infection, obviously we'll do all our usual culturing business, but actually what you want to do then is overnight, what would be really useful is to book a HRCT, a high resolution CT. So most fungal infections will hide in the lung. So most invasive fungal infections in this setting will hide in the lung. So a HRCT for some cross-sectional imaging of the chest is really useful. And what we'd also send is something called a beta-D glucan and galactomannan. So these are funny tests, so serological tests that we send in the blood, and effectively they serve as a bit like a CRP for fungus. It's a slight misnomer to say that. It's not quite the same, but effectively the higher, so a galactomannan tends to tell you that there's aspergillus, which is a type of invasive fungus. Beta-D glucan's a bit more, it covers a few more, it's a bit less specific, that's what I'm trying to say. But actually what you can tend to see is patients that have, you know, rip-roaring PCP or aspergillus will have a very high level of one of these, and as you treat them and they get better, this will fall. So that's kind of what I'm saying about the CRP. So you can search for those on ICE, and again, it's just one of those useful things that if it's just stuck out for the morning, it just saves everyone a job. And the problem with those serological tests is that they go to Bristol, so they take, well, it depends which run they go on. So sometimes it can be as little as a couple of days, but sometimes it can be a week or so before you get a result. So it's good just to get them off and send them early. And we tend to start things empirically. So again, at this point, you'd want to discuss with one of us about what to add in. But what they can do is they can give us a really good basis for stopping if they're negative or continuing if they're positive. So it's good to send those things off. And it says here consider bronchoscopy, but that's kind of up to us, and there's decisions to be made around that as well. So generally speaking, at this point, if we're going to start empirical antifungals, would give caspofungin, which is kind of a broad sort of cover. Sometimes we give an azole, so voriconazole, posaconazole, etc. Again, there's lots of sort of reasons for and against all those things, and I think it's probably a bit outside the scope of this. The only difference, I guess, with the allogeneic transplants is that we're a bit more keen on escalation of antibiotics. But I think from your perspective, the outcome of this should be, if a patient's gone 48 hours on the same antibiotics and are continuing to spike, then reassess, reculture, and discuss. Unless there's a clear plan that says, if spike, change this to this, then obviously you can do that. But I'm usually more than happy to take these things, and we tend to hand over at 5 between us, registrars sort of say, you know, what's the escalation antibiotic? So we'll usually have it on our list. So when you ring, it's usually just a quick, oh yeah, it's this, thanks. So that's what we do. And then coming back to this slide again, which some of you have seen before, the sort of golden rules of neutropenic sepsis. So we do want you to culture everything. We do want you to give antibiotics within 1 hour where possible. I think with electronic prescribing, that should be a little bit easier, but do be careful with allergies. Do prescribe correctly. That's a good golden rule, isn't it? Paracetamol, PRN, is useful for nurses to try and get the fevers down. Please don't wait for the full blood count. If you don't have one, so assume that they are neutropenic. Don't wait for the culture results. Don't think, oh, I'll just send some cultures and see what happens. And please don't wait for the patient to get sick, because it's quite annoying when you're sort of battling with ITU for pressors and things, and it could have all just been resolved with just a simple spike and a patient telling you the next 4 days that they really didn't think they had an infection, but they probably did. It's just that you did your job perfectly and started the antibiotics early. We try not to perform PR exams due to risk of translocation of bacteria from the bowel into the bloodstream. And we said don't insert catheters. Well, it just depends on what the situation is. If someone's really sick, I want a catheter. I want to know what the urine output is. If someone's absolutely fine with a bit of a fever, then perhaps we can hold that off. And again, our nurses are excellent at monitoring the urine output either way. So I think that's just one of those things that I just tend to do if someone's sort of hypotensive and I really want to know what their urine output is. And the other thing that said don't leave on prophylactic antibiotics, so I can't talk. So some of our transplant patients will be on things like ciprofloxacin and metronidazole there as prophylaxis. So if someone starts on sort of, treatment antibiotics, then they can be omitted when you start those. So that was neutropenic sepsis. Any questions? No, lots of shaking heads.
I'm okay,
cool.
Thank you.
All right. So case 2, a little bit different. So you're on your shift again, and O1 ring you because a new patient's come in. It's a 19-year-old man who's complaining of left leg pain and has a background of sickle cell disease. So does anyone know what approach you'd take to this sort of patient if you happened to come across them?
Would we ask them what kind of pain it is? Well, do an ABCD, obviously, and then ask him what kind of pain it is and what the medications they're on and whether it's legal in it.
So yes, I mean, you're going to do a Clarking, aren't you? But I suppose what we're trying to allude to here is what do we think is going on and what are important questions to know the answers to. So I appreciate this was a bit more tricky and perhaps some more and again, these tend to be the patients that either we want to know about via phone or in person. So we'll go through the history. So he's had a painful left leg for about 3 days now. He's been trying to manage it at home with paracetamol, ibuprofen, but it's just not doing the trick, and he's now in a significant amount of pain. And this is all in the background that he does get intermittent hip and knee pain that sort of settles with simple analgesia for the most part. He doesn't take anything regularly. Perhaps he should. And his blood pressure is absolutely fine, temperature fine, respiratory rate fine, fat's fine. And he's got a little bit of abdominal pain and a bit tender there as well. So what's the most common cause of pain like this in a sickle cell patient? Does anyone know? So this is a really common presentation for sickle cell. So sickle cell disease is a disorder of the hemoglobin content of the red blood cells. And basically what it means is that when the hemoglobin is deoxygenated, it basically solidifies, it polymerizes and crystallizes within the red blood cells and makes the cells abnormal, sort of a sickle shape, hence the name. And that basically leads to lots of problems. It's quite a complex sort of pathophysiology, but in a nutshell, one of the most common complications of that disease process is something called a painful or vaso-occlusive sickle crisis. So on a simple level, what's happening is that the abnormal red blood cells can't bend and fold through the really small blood vessels, as well as a normal red blood cell can. So they basically block these tiny little blood vessels and cause all these little microinfarcts of bone. And it can be excruciatingly painful for the sickle patients. So these guys tend to live with sort of, pain day in, day out, and are really good at managing it actually, usually at home. And they only come in when they're really, really struggling. And it's usually quite distressing to see them. So in terms of managing these patients, there are guidelines on the intranet, and they are patients that us as registrars on call absolutely 100% need to know about. But in terms of, basics and just kicking things off, so we tend to send some bloods. We tend to ask them about what potential precipitants are. So something as simple as a guy recently who just really wanted to go swimming with his kids. And every time he went swimming, he just got a really horrible, painful crisis. So we say cold can precipitate it, but it tends to be that changing temperature, like going from hot to cold, that would change it. Infections are a big driver of, or big precipitant of painful crises. Falling blood counts and lots of other things as well. So we tend to sort of go through those. So look, basically what you want to know is, have you been doing anything recently? Have you taken any medication and any symptoms or signs of infection? And then really what they need is pain relief. So there's a whole guideline on what to prescribe, which I'll show you in a minute, but it's absolutely vital that these guys are taken very, very seriously, because they often are in sort of excruciating pain. As I've said, we absolutely want to know about them. So this is our Sheffield Teaching Hospital guidelines for the management of painful crisis in terms of analgesia for sickle cell patients. So there's sort of two pathways depending on whether they're taking opioids at home or not. And this is available on the intranet, but obviously I've put this up here so that you can all see it. And effectively, it's just painkillers that you'd expect, plus pregabalin. There are a few of our patients who are significantly more complicated than this, and we tend to manage their analgesia. I was going to say in combination with the palliative care team, but really the palliative care team really take the lead. So there are a small group of patients who tend to require palliative care input almost as soon as they arrive. But again, that's the importance of sort of giving us a ring, because we tend to know who they are. So there's a nice guideline for you to follow. And again, if it's just someone straightforward who doesn't come in often, then often this is absolutely adequate, and we'll escalate things as we go. So the other thing that we give this patient is, I swear I've not changed these slides, I thought I had. The other things to consider in this setting is IV fluids. So traditionally, we used to really make these patients really well hydrated to try and get over that sort of blockage, if you like. However, I'm not entirely sure that pumping loads and loads of fluid in is the best thing. So if the patient's dehydrated or they're not able to drink, then absolutely give them fluids just to either sort of rehydrate or maintain them. But actually, if they can drink 2-3 litres a day easily, then often they can manage with that. I usually just ask them. Some of them like the fluid, it gives them some relief. Some of them hate it, so I just tend to ask what they'd want. And the other thing a bit like that is oxygen. So in these patients, if they've got normal oxygen saturations on air, I'm happy for them to have PRN oxygen. Some of them hate it, fine. Some of them really quite like it and find that it really helps. If they're hypoxic, that's a different matter, which we'll come on to, but PRN oxygen is also useful for these patients. So quick history, look for precipitants, bloods, if you can get them, pain relief as per that guideline, and consider IV fluids and PRN oxygen. And obviously, if you think there's signs of infection, then we need to think about antibiotics as well. But as an absolute bare minimum, this should all be discussed with one of us. If not, we'll be seeing them anyway. But that's just so you know what's going on. So that was all done. And actually, pain-wise, this young man's getting better. But the next evening, he's just not looking quite right, and you have to come back to have a look at him. So he's still in some discomfort, but actually, generally speaking, his leg pain's loads better. But now he's got chest pain, and he's spiked a bit of a fever. He's become hypoxic, so his sats are now 89% on room air, tachycardic. Any ideas, anybody, what you think might be going on?
Could it be like an acute chest syndrome?
Yeah. So what do you know about acute chest syndrome?
Not a great deal. I've always assumed it's similar to well, just being really like prothrombotic, but maybe not.
Okay. So acute chest syndrome is absolutely 100% one of my priorities in this situation. Anything else?
Potentially an infection, maybe a chest infection. They're quite susceptible to infections.
Absolutely. So in a nutshell, with these patients, you think it could be anything that could normally be for a patient, like chest infections, PEs, and all the rest of it. But equally, you've got to add that sickle dimension. So in this particular instance, the concern that we have here is something called an acute chest syndrome, which is another complication of sickle cell disease. So what if you were faced with this? The SHO's stuck at Western Park and the MedReg is doing something else, and you were just trying your best to be helpful because you're in the vicinity and the patient had low oxygen sats. And you just thought, right, I'll just try and do a bit in the first instance. What would all of you do?
Ring you.
An
Are you going to
ECG.
see the patient? Are you going to see the patient, or are you going to ring me and then see the patient?
See the patient and then ring you with what findings.
In this particular setting, if you want to ring me and then go and see them, that's absolutely fine, because it might be that I've got dressed and got into the hospital by the time you've finished seeing them. But either way, if this happens at any time of the day, I'm probably going to come. So ringing me is a very good plan. But I think obviously in this situation, you can ring me, but you do need to try and sort of do a few bits just to at least, correct things like the hypoxia in the first instance. So we said ABCD is normal. Obviously oxygen, given that it's hypoxic. Pain relief for his pain. We want an ECG because, we could have chest pain for a completely different reason. And then we want a chest X-ray. So it's really annoying because I did edit this presentation, but I've clearly got an old version of it and I had some nice pictures. So a chest X-ray in an acute chest syndrome can look abnormal. So basically, if you're having an acute chest syndrome, it can look like it basically looks like you've got consolidation on your chest X-ray. So it can look like you've got an infection. It tends to start at the bottom and then work its way up. So what we tend to say is that if there's middle zone or upper zone consolidation first, it's more likely to be an infection. However, there's no guarantee either way. So a chest X-ray in this setting is obviously of absolute paramount importance. So you could ring me, go and see the patient, stick them on some oxygen, get them an ECG and book them a chest X-ray, and save me a job when I get there. I put query ABG, so I don't want you to take this home. I just like to heart properly. I just want you to, if the sickle patient's hypoxic, that's a concern. But sometimes because of the sickle, they don't pick up on the SpO2 as well. So we do sometimes think about ABGs, but I think anyone that's hypoxic on the SpO2, just take that seriously and go through these motions if we haven't already, and obviously discuss that with us. And then the other thing here is to think about antibiotics. So again, I think in this setting, we're not sure. Even if there's change on the X-ray that you think it's an acute chest syndrome, then we'd still give antibiotics anyway. What we're like with antibiotics, very liberal. And then, as you've all pointed out, the most important thing really is to let us know, because this is, and again, it's annoying because I've not got it, but this is basically a life-threatening complication of sickle cell disease and requires quite complex but very urgent treatment. So the definitive treatment for this is something called a red cell exchange transfusion. So that is basically sticking them onto an apheresis machine where we allow new blood, so transfused non-sickle blood, to go in and then take off the patient's own blood. And the idea is that you're reducing the percentage of cells in the bloodstream that are sickle, and that can help resolve the situation. That takes quite a significant amount of organising. So patients often need central lines. They have to go to theatre, get a line in, and then you have to make sure you've got blood. And because these patients are difficult to cross-match, blood sometimes comes from all over the country. So that can take time to come in. And then you've got to get the therapeutic apheresis nurses to come in from wherever they are, and they do a regional cover, so sometimes coming from as far as Harrogate. So when this happens, if we're worried, it just needs to sort of start, the process needs to be ticked off really, really quickly, because it can be lethal. So if nothing else from that, just take away that we want to know about it 100% straight away. So again, hopefully you're less likely to be involved with this, but the idea was just to give you an appreciation of the seriousness of it. Because I think sometimes, we see a young person, a 19-year-old with a little bit of hypoxia, and we think, it's fine, a bit of oxygen, a bit of antibiotic. But these are the patients that they're the only ones that still, give me significant anxiety about. So take them seriously with their pain, take hypoxia very, very seriously, and just keep us updated at all times. Good. So I think it's Jack's turn now. Probably taking a bit too long, but Jack can take over.
Oh, Jack, can I just ask a question? If they've got chest pain, would there be any common presentations on the ECG, like T-wave inversion or increased PR interval?
Oh.
No, nothing like that.
No, the ECG would really be looking for something else as a cause of their pain. But the problem with most simple problems is that there's no defining test that will tell you what's going on. It's all incredibly complicated, and often it's a case of experience. So even when I come to see this patient, I tend to be on the phone to the consultant, or even ring the consultant that's not on call, which is Josh, because he's the specialist in this. And it's not out of the ordinary for us to ring Josh when he's not at work and just be like, what should we do? Because sometimes you don't know what's best, because there's complications of the exchange transfusion as well. And sometimes it's holding your nerve, sometimes it's not. I'm not a fan of the nerve holding. I'll leave if that's going to happen. That's very much a consultant decision. But there's no specific marker of what's going on. It's just kind of putting it all together basically, and covering some bases like infection whilst you're getting things sorted. Mm-hmm. So, yeah.
Okay, thank you.
So if we just move on to the next case, if that's all right. So you're on call once again one evening, and you get called to the called by the day ward. There's been a new admission this evening, and you're asked to review this 68-year-old gentleman that's got a background of multiple myeloma and has come in off legs, as it were. And if we go to the next, yep. And so I'll give you a bit of a background, and then we'll discuss it if that's okay. So as I said, he's a 77-year-old gentleman. He's got a background of IgG myeloma. In the past, he's had 5 cycles of chemotherapy, and then that's been consolidated with a autogenic stem cell transplant, and that's all 3 years ago. And he's done really well since then. So he's just been under surveillance by the hematology team and is not has been any further chemotherapy. But his wife's been a bit worried about him for the last week. Patient's been holding his back quite a bit, and his legs keep giving way, and he's been a bit confused. He's not quite himself. He's usually very lucid, but he's been a bit confused. And we'll just move on to the next slide.
Sorry, Jack.
So what other questions would you want to ask this patient and his wife when they come to the day ward at the moment?
I'd like to ask him how they've been feeling. Has he been having any fevers at home, any nausea, any vomiting, any pain anywhere, and what's relieved it if he's taken anything?
Yeah, exactly. Yeah. So what's he been taking for the painkillers? Any temperature is important. Abdominal pain. Any other questions about his back pain specifically?
Any incontinence?
Yeah.
Yeah, exactly. Yeah. Has there been any bladder or bowel incontinence, or as a patient, when he's been wiping his bottom, has it been numb? And then again asking about, is there any numbness in his legs or weakness in his legs? And I guess other things I think about this gentleman, we said he's had weak legs and has been falling over, and he's now confused as he hit his head. And what would you want to do? How would you want to examine this patient? What specifically would you want to examine?
I think he needs full neurological examination, see if there's any weakness, whether it's bilateral, unilateral, like that sort of thing. Probably, if he's a bit more confused, I'd probably do a cranial nerve assessment just to make sure there's anything like out of that. Full A to E, obviously, but
Yeah.
I'd be interested with a neurological examination.
Yeah, I completely agree. The only other thing I know, Jack sort of touched on this, but I think in this situation, a PR exam would be quite important. This patient's unlikely to be neutropenic. They've been doing well, so I think I'd want to do a PR exam with someone who come with back pain and myeloma. And what initial tests would you want to do at bedside, or anything specific, or any blood tests that are specific you'd want to do?
I'd be looking for bloods for an infective cause and tying up a neurological exam really from the bottom end, because it's sort of risk of cord compression I thought would be the major one. Yeah,
exactly. Yeah. And just I think absolutely right. I think in that line it's not crucial, but sometimes a post-void bladder scan, it's quite a common and if we just move on to the next slide, and we'll just go through some of the initial findings that we have. So he is a bit confused. So he's got on his GCS, he's got some confused speech, and he's weak. He's got weak lower limbs with areflexia, and he's got reduced anal tone in PR examination, and does look to be in urinary retention in a post-void bladder scan. So absolutely right, this gentleman does seem to have, it certainly does seem to be a spinal cord compression, and with that absence reflexes, that's sort of keeping the lower motor neuron signs of the chorda equina. So how would you want to proceed at the moment with managing this patient?
Investigation, so CT, MRI, probably steroids if we think that it's a risk. I don't know if I'd want to scan his head to rule that out as a cause of anything going on sort of upper. And then I'd want a senior to know about it, so I'd be on the phone to you guys. Yeah,
exactly. Yeah, no, that's that's spot on. Yeah, so I think if we on the next slide we'll just talk about, I think you're absolutely right. I think is speaking to in this situation, you want to speak to the haematology registrar immediately, because you're worried about spinal cord compression, and you want to get an MRI of, if you're worried about spinal cord compression due to malignancy, an MRI of the whole spine, and to give some steroids, and if this patient's in retention, you'll need a catheter, and then obviously this patient's going to need the MRI, and then once that's done, to send the refer a patient to the neurosurgeons. And then this patient will be for consideration of surgery if there's a compressive lesion, or if that's not appropriate, possibly radiotherapy. And again, this is just an image. This is from a website called Radiopedia, and it's got quite a number of discrete punched out lesions, and that's sort of they're lytic lesions, which you get in multiple myeloma. So I think from this case, just wanted to highlight the importance of, if you asked to see someone with myeloma and back pain, just to think, this could be a presentation of cord compression. But unfortunately, it doesn't end there for this patient. He's having a terrible time. So his calcium level's back and it's raised. What are you going to do at this stage?
Would we give some fluid to hydrate him to reduce that calcium?
Yeah, exactly. Yeah. So you want to give fluid. Yep. Anything else at all?
ECG in consideration of bisphosphonates.
Yeah, exactly. Yep. And so if we just go on to the next slide. So yeah, exactly. So hypercalcemia, it can be the main causes, or it can be due to primary hyperparathyroidism, but in this scenario, it could be due to a malignancy, whether that's a solid organ tumor or from a hematological cancer. And the rhyme we use to describe the symptoms are bone, so bony pain or pathological fractures, stones, so kidney stones, abdominal groans due to constipation, or psychic moans, so patient could be delirious. So again, as a theme, as the main talk of this situation, you want to get on the phone to the hematology registrar. This is quite a serious medical complication. I think things you want to do is look at his medication to make sure there's no medicines that could be contributing to this. So things like thiazide diuretics can cause a hypercalcemic picture. And as mentioned already, this patient's going to need quite aggressive fluid resuscitation, and is going to need very accurate fluid balance, so an accurate input-output chart, and possibly even a catheter in this situation. But again, taking into considering comorbidities, because these myeloma patients are often quite old and frail and may have renal failure or heart failure as well. And then again, the other thing to consider about is bisphosphonate therapy. Once they're rehydrated, but again, that would be up to the registrar consultant, and that can take a few days for that level to come down. Is there any questions at all from that case?
Jack, would you have any concerns or anything about a myeloma patient that might make you slightly more worried about giving a bisphosphonate? So something that's intrinsic about what myeloma does to you that might make giving bisphosphonates tricky?
I'm not sure, to be honest, of what you're concerned.
I'm just thinking, because they can present with hypercalcemia and acute renal failure, and obviously there are contraindications to giving bisphosphonates at certain creatinine clearances. So I think if anyone's thinking about giving a bisphosphonate, do make sure that you check the creatinine clearance and the SPC to make sure that it's safe.
Thanks for that, Jack. Any other questions or at the moment?
I was just going to ask if you have they've have any hemodialysis.
I think if myeloma, I think if patients in myeloma do have a hypercalcemia that's contributed to an acute kidney injury, then yes, patients sometimes do need hemodialysis if the renal function isn't improving. So yes, that can sometimes be an option. And if it's all right, we'll move on to our last case, if that's all right. So again, you're on call again, and it's coming up to 5 o'clock, and you're getting handed over by a job by one of the junior doctors at the end of the day, and they're just saying, "Oh, can you just chase these blood tests for this patient with AML who started induction chemotherapy?" So if we can just get the blood results up. So these are the blood test results. Does anyone want to make a comment on some of the results, and then maybe what we're thinking or worried about in this case?
The hyperkalemia is 6.2, so that needs treating first.
Yeah, exactly. Yeah, that's a worrying level, isn't it? Yeah.
Hyponatremia.
Yeah.
2.8 and dodgy kidneys with a raised creatinine.
Mm-hmm.
And the phosphate and the corrected calcium's low as well.
Yes. So yes, I think yes, you're right. So yes, the phosphate's on the high side, and the
sorry, high, yeah.
Yeah, sorry. No, I should have put references in, and the calcium is most definitely on the low side. So yes, he's got a hyponatremia with renal impairment and a hyperkalemia and a hyperphosphatemia and a hypocalcemia. I don't know, does anyone think of anything that might tie those results together? Potentially, on someone that's on AML on chemotherapy?
It flashed up on the screen before hemolysis syndrome.
No, I think that's absolutely right, yeah. And then we'll go back to the next slide. So yeah, tumor lysis syndrome. So this can occur in cancer patients that are receiving chemotherapy, and it is more common in these sort of liquid tumors rather than solid organ tumors. So common in leukemia or lymphoma, and it is a set of both clinical and biochemical findings, and it's something that we need to take very seriously and can be acutely life-threatening. And the next slide will just show the criteria for it. So this isn't something necessary to commit to memory, but it's just an example of the criteria that is used for tumor lysis syndrome. So to make the diagnosis, you need sort of 2 of the criteria on the left under the laboratory criteria, and then 1 of the clinical criteria on the right. And then if we go to the next slide. So again, yeah, so like a lot of things in medicine, so the best way of managing tumor lysis syndrome is try to prevent it. So that's why patients need to be carefully assessed before starting chemotherapy and decide if there's any measures to try and prevent it, such as admission with IV fluids or allopurinol or respiracase and regular blood tests. And so again, they need to be assessed in a ATE manner with speaking to the hematology registrar very early on, and we'll need cardiac monitoring and treatment of the hyperkalemia. And the other thing just to note of interest is the calcium. You wouldn't replace it unless they're symptomatic, because patients in this scenario can get calcium phosphate crystals in their kidneys, and so if that was to happen, that could worsen the renal function. And this patient might need supportive therapy in the critical care setting or with the renal physicians. Is there any questions at all at the moment? I think that's the end of the presentation.
Is that a historic hand, Nazia?
Yes, it is. Sorry, I tried to take it off, but it says it put me in the spotlight, but I don't want to be in the spotlight.
So that was a bit of a whistle-stop tour of a few things that I guess you can come across. I think other things that you come across tend to just be, things that you meet elsewhere in the hospital, but obviously happening in hematology patients. So hopefully you know what you're doing with those. So with everything that was said this evening, or even anything that was said for those of you who've been here at all 3, is there any particular questions, or forgetting the teaching, is there any kind of worries, concerns, anxieties, questions, anything about anything that you've seen in the last however long?
Jack, I treated somebody for query allergic reaction recently. He was on, I'm not going to pretend to know what it is. Campath, yeah. The patient had it as an outpatient. He'd had a first round of it as an outpatient, and he'd been all right on it, but he quickly became quite hypotensive, tachycardic, dropped his conscious level. So the nurses sort of escalated him from a reaction rather than an infection point of view.
Right.
But I was just wondering how, if he'd had it before, what was the chance that it could have been a reaction? I guess you probably need more details regarding his dose and everything, but I thought sort of it was unlikely, but then they said that it can sometimes happen with the second dose.
So I think there's probably 2 things to say there, in the sense that for genuine allergic proper anaphylactic reactions, then you're quite right. If you've had multiple doses, then it's very unlikely that you're going to get a proper anaphylaxis. However, anaphylaxis in itself, you tend to have a sensitizing event, don't you? So the first dose, you might get, you know, a bit of a rash and feel a bit funny. And then the second dose, that's when you go, you know, bonkers and need adrenaline. The second thing to say is that Campas's a weird drug. So it it gives you the anaphylactoid type reaction. So they're not necessarily full-blown anaphylaxis, but they do present like that, and often we treat them in a very similar way, but it's probably a slightly different mechanism. And I think when you're having Campas, generally speaking, the worst reactions after the first infusion. So there'll be lots of patients on P4 who start their Campas, and within a couple of hours, I get a phone call to say they've come out in a horrid rash, they can't breathe. Then actually you just stop the infusion, give them a bit of steroid, and they get better, providing that they're not, you know, this guy sounded worse than that. But I think if I was you, I know which patient you're talking about, and I was approaching that patient on the day ward, I would, you know, consider a reaction and an anaphylactic reaction, but I wouldn't just completely dismiss sepsis in that setting either. On exactly the same. So I think what you were trying to say is, do I just discount sepsis? And I think the answer to that is no. But I think the problem is often in these situations we're giving such complicated drugs that do weird things, and often there's like a multifactorial thing going on, that in that acute setting, actually, as long as it's safe, covering for infection as well as a reaction is probably the right thing to do, rather than just sort of saying, oh, it's definitely this one, not that one. But with so anaphylactic reactions tend to occur after the second hit, don't they? You usually have a sensitizing event. But with Campas, it's a weird drug that just causes reactions. Tends to be like an urticarial rash, bit of breathlessness, wheeze, all those kind of anaphylactic-y type symptoms. And in that particular case, I would be more than happy. In fact, I would encourage, and I would personally cover for both.
Yeah, I just gave him everything.
Good. Yeah, no. Well, he's still here, isn't he? So.
Is he no good?
Yeah.
Thanks for that.
It's all right. Any other things that anyone come across, or that you confuse you, or you just don't get, or are you all fed up of me? You've had 3 weeks and you just want to go and get on with your evening. That's what Jack feels like. He has that 3 months with me. That's why he moved to Newcastle.
No, thank you. It's been good. Good 3 weeks. We've enjoyed it.
Well, we enjoy doing it, and there were others of my colleagues that wanted to do it as well, but for various reasons couldn't. So if you ever want to do it again, you know, on anything different or the same stuff, just get back in touch, and either me or someone else, I'm sure, will be more than happy to do it. And we've usually got loads of keen SHOs that are trying to get things on their CVs and things that are like really, really keen on being involved as well. So just use it and abuse it. And please fill in feedback, because it's really helpful. Because at the moment, me and Jack have tried to pitch it where we think it is, but we've probably got it slightly wrong. So just tell us and we'll change it and make it more what you want. Because at the moment, I just pitched it at a practical level, but you might not want that, and you might want a bit more detail. So just tell us and we'll change it.
Brilliant, thank you.
Thanks, Jack. Just from a feedback for us generally, when you get phone calls in the middle of the night, is there anything glaringly where we could improve? Is there anything that you particularly find that we regularly miss out? Is there anything that would help us help you?
Not really, no. We're just, I think, eternally grateful that someone's going to see our patients. You know, it can get it's like boom or bust at the Hampshire, isn't it? Either like nothing's happening or everything's happening all at the same time. So I think just having someone sensible that can approach a patient in a proper way, do the basic things, you know, and start building on that. And then, you know, at that point, more than happy to take a phone call, knowing that we can just add. I mean, often we don't add much, do we? We just usually say, or just change this and do that. So I think, can't speak for everybody because I haven't asked everybody, but I think as a whole, we're very, very happy that people are just willing to come and see our patients and help them out. Because they do get sick, don't they?
Yep.
Yeah, certainly do. Thanks so much. We've really appreciated it.
Yep.
All right. Anything to say, Jack, before we go?
No, nothing inspirational. No. Thanks for letting us do it. It's been it's been great experience.
Cool. All right then, everyone. So just if anyone needs anything, you can just email and